Are we live?
Not yet. And here we come. Hi, eGP learners. Sorry for the slight delayed start and the interesting way that we're starting. We're having some slight tech glitches, but we think we've sorted it all for you. Welcome to the eGP Learning Podblast episode with myself, Gandhi, and
Andy. Hello.
So this is our kind of new format, digital updates that we're going to be doing. So short, sharp updates and stuff. And just to let you know about a couple of things that we've got coming up for you. So for those of you based in Nottingham, we've got our Health Innovation East Midlands events on March the 26th, where we're having effectively a debate, aren't we, Andy?
Yeah, it should be very exciting. So a big tension in health technology, and particularly around the use of data, is privacy and data security versus data availability and the good that access to that data could do.
Yeah, so we're going to have a debate at our next Health Innovation East Midlands event about these kind of concepts and which one's kind of more valuable, and I guess the question is valuable to whom as well.
Yeah, absolutely.
So if you want to join us, it's March 26th at the Antenna in Nottingham City Centre. We kind of kick off at 6 o'clock, but the debate will probably kick off a little bit later on, so we get people the opportunity to network and stuff. And if you want to sign up, the links will be in the show notes, or if you want, you can go to bit.ly/Health Innovation EM3, all lowercase and stuff. So definitely sign up to that and things.
And we'll get it in the show notes, won't we, Gandhi,
Yeah,
so people
definitely.
can see that.
And free to attend. And next quick little thing we want to mention. So on Wednesday at 10:30 in the morning on the System 1 Facebook user group. So if you're not a member, it's S1 FBUG through Facebook, and then you'll be able to apply. Make sure to remember to answer the questions that let you in, otherwise I won't let you in. But at 10:30 in the morning, we'll be having a live demonstration of the AccuRx system that many practices started to use because they've just kind of gone on to System 1 recently. A lot of EMIS users probably have already got access to this. They've been doing really well with that, and it's a really interesting way of using text messages to communicate with patients on an individual basis. So definitely feel free to join us for that. Not affiliated with the company at all or anything like that, but just wanted to show the tech really. For those of you that can't attend at that time, I appreciate 10:30 in the morning on a Wednesday is probably not the best time for all clinicians to attend. It will be available on the eGP Learning channels on YouTube and Facebook and everything the following day, because we'll process it for the episode then. So feel free to join us.
Right. And other exciting news from Gandhi's System 1 Facebook user group as well. Gandhi, you've got some exciting news about an upcoming event later in the year.
Definitely. So many of our System 1 Facebook users will know that on the past few weeks I've been trying to inquire about how they'd like a conference effectively, and we've just had some really great talks with TPP, and they're supportive of this idea that we can help run an effective user conference for primary care when it comes to System 1. So we haven't got an exact date, but one of the things we can tell you is going to be in September of 2020. It's probably going to be Nottingham, so you will need to factor that in, and we will clearly get more information to you guys as this evolves, and hopefully within the next couple of weeks or so we'll have something up and ready for everyone to start signing up to. But just to be clear, September this year, System 1 Facebook user conference, or whatever we're going to call it. But
yeah, it's going to be extremely exciting, and
we've
got some great ideas for making that a good event. And I was really impressed by the feedback that Gandhi was able to obtain from the user group. Lots and lots of data and comments about how to do an excellent conference.
Yeah, so thank you to everybody in Team S1 FBUG for all their feedback, because it has really helped, and System 1 have been really impressed with the comments that we've got from this to help design this conference with them. So yeah, definitely looking forward to that.
Good. So this is the first of our live update sessions. So Gandhi, what's the format going to be this morning?
So we're just going to cover a couple of news articles that we've come across over the past couple of weeks relating to effectively digital primary care or health technology in primary care, whichever way you want to look at it. And what we're going to talk about is basically briefly introduce the articles, give you a little bit of our opinion in terms of the kind of content and stuff, and then we're going to finish off with our podcasts of the week and then let you guys get back to your weekend.
Yeah, so thanks for joining us for your Saturday morning clinic, and let's crack on. So Gandhi, the first story is about notes digitisation, I think. Do you want to start introducing the story while I try and switch and get this on the screen?
Yeah, definitely. So these articles, both of the ones that we're going to talk about, come from the HTN News Network, so they're our sponsor for the eGP Learning Podblast and stuff. But this one's talking about, like Andy said, the digitisation of records. So this was part of the original GP contract changes that came in last year and still waiting for it to be clarified. But the big news with this is that there's going to be a procurement process done by NHS England, effectively looking at how the digitisation process is going to work. So they've clearly got some ideas of how this might work, but it's going to be a national procurement process to find people that basically can do this for primary care.
Yeah, and that process will launch in April 2020. So I think the actual implementation of this is probably some way off. Hopefully sooner rather than later, but they're going to be starting to look for suppliers and providers in April 2020. And Gandhi, do we have any idea about how this might actually work? Is there going to be one national provider? Is it going to be a regional procurement exercise? Do we know?
Don't think we do, unfortunately. There's not much clarity in terms of how this is going to work. So is it one big provider for the entire country? Don't really think so. I would struggle to see how any one company could do that.
It's a lot of work.
It is a lot of work. So I suspect it may be more like what's called the DPS, the Digital Procurement Service, that happened when it came to video consultation, online consultations. NHS England will have a list of providers that basically fit the bill, and then each regional areas will be able to go to these providers and say, can we do this? Clear question of how it's going to be paid. So this is meant to be being paid for by practice rather than practice having to pay for it themselves. Be interested to see how that works.
We'll see how that works on the ground. So, Gandhi, what do you think the implications are for us GPs in practice and on the ground?
I think, so there's definitely implications in terms of how this works. So there's going to be the process itself, which although practices are being told they won't have to pay for this, there's definitely going to be some opportunity costs that come into it in terms of releasing staff to help support it, the time it takes to do, and possibly integration.
Yeah, and there's lots of issues, isn't there? Who will do it? So I know that large back office activities have been procured to companies like Capita in the past.
Yeah.
How do you think that would work out, Gandhi?
So we briefly chatted about this, and I was a bit more vehement in my response from this. But clearly, if NHS England decide to give this a contract to Capita, then they really need their heads looking at long and short of it. So
they've had some bad experiences, I think, with Capita.
Everybody's had a bad experience when it comes
doing
to
business
this. So clearly, even if Capita turned around and said we'll do the entire country for £1, I'd still say that's more than it's worth.
Well, they're not going to be able to deliver with that.
Yeah.
So, let's look at some of the positives first.
Definitely.
One thing that stares me in the face when I walk in my building in the morning is that the records take up a lot of space. We've got about 8,000 patients, and there is a large area. It's not a separate room in our surgery. It's a large area of our reception back office. It's a huge amount of space, and we could do a lot with that space. So actually, just on the fundamental level of removing the patient records from the surgery, I think we could do a lot. What would you do with your extra space, Gandhi?
So I think there's different ways you could use it. Like you said, you've got potentially the opportunity to free up admin space depending on where this location is. You could look at putting consultation hubs. I think, digital consultation hubs and stuff, and actually reviewing something that may help with that in the near future. So keep your eyes out for that episode.
That's good. I hadn't thought about that. But actually some video consultation, electronic consultation workstations in that space would probably work, particularly if you can do what you need to do around the privacy bit with headphones and screens, as in physical screens to stop people overlooking.
Or even focus on the well-being side of things. Give your staff an area that can be, for example, a cycle that they can jump on for 2 minutes, get their fitness in and stuff. Look at the well-being of your staff. Not
a Peloton machine.
Yeah, let's go for it.
That would be good.
But it's important to remember that other practices do different things. So some of the larger practices may actually be paying for off-site storage because they don't physically have the room, and actually, therefore, there's an opportunity cost that those practices will have in not having to pay for that service, because these notes are big. There are some patients with huge
Depending
notes.
on some patients have multiple notes.
And I guess one of the things we'll see as a result of that is therefore hopefully the improved transfer of information when it comes to this. So, the fact that it's more easily searchable with patient data, records and all that kind of stuff, and transferable, and all this having to wait 6 weeks for the physical notes to arrive.
Slight tangent, but I've always wondered about the form factor. The Lloyd George form factor? Even just if they'd have just transferred years ago to A4, that would have saved so much time in terms of unfolding every letter that you need to read. But sorry, that was just a little bit of random venting there. But leads us on to another advantage, which would be access to the information that's within the notes. It does depend on how they deploy it, whether we just get a file full of PDFs of each page and nothing more,
Yep.
or whether they do something more creative and do some optical character reference and actually create some searchable text within the notes. Some of the old handwriting would be difficult for
Yep.
the old GP consultations. However, there are a lot of letters in there. So being able to access the information within those letters would be really, really useful and valuable when patients come in and we need access to that information for their care.
Yep, definitely agree. And I guess the other part that will be interesting to know from the procurement process, whether optical recognition will be part of this or whether it's just going to be pure scanning. Because there's going to be clear implications in how practices can use that information. And then the other one, again, we're going to talk about it quite often when it comes to digital stuff, is interoperability. Our practice is going to have to look at a separate system to access this information, or will it be already integrated within their clinical systems, which is clearly better, more timely, and less stress, basically, or not really. So it'd be interesting to see how this works from a perspective of the outcomes.
And who and how will it be coded as well? Yep. And will it be coded, I suppose? It would be very useful, but then the quality of the coding is important variable as well.
And every practice does things differently, which I appreciate is a challenge in this kind of thing. Because every practice does things completely differently, how that's going to work is an outcome issue, really. So some pros, some cons. I think generally most people think it's a good idea and it needs to happen.
It's about time, I think.
Yeah. Definitely.
So that's good. It's nice to see it happening. It's nice to see that they are making an effort to absorb most of those costs centrally. But I do take on board your comment. I mean, I can't see there being no input required from practices and no cost falling to bear on practices. So we just have to be careful with that. But on the whole, I'm positive about this.
Yep, as long as it don't go to capita.
Good. So
going to stick that in there. Sorry, guys. Yeah. So our next news story. What have we got, Andy?
So this is another interesting news story. So this is about a pilot that Boots are running across 20 of their stores in London, partnering with what looks to be a video consultation, video doctor service. So it's what's the name of this one? Can you help me?
Doctor Care Anywhere.
Doctor Care Anywhere. That's fine. It wasn't in my notes. They're partnering with them, and it's actually a little bit difficult from the story to work out exactly what is happening.
I'd agree with that.
But it does look like they're partnering with them to deliver better access to requesting of scripts and reordering of scripts, which doesn't sound as groundbreaking as the headline might have said. But it raises some interesting questions. So, Gandhi, what do you think about this story?
So, Boots are going to be providing this in a London-based pharmacies. So that's the first thing to mention. It's 20 of their London-based pharmacies they're looking at providing this for. And like you said, it's not 100% clear what service this is actually going to deliver. It kind of comes across as them being able to just request their repeat medications, which, to be honest, doesn't sound like the best use of time. What I hope is it's actually going to be is therefore patients have the opportunity to have a consultation with somebody, either a pharmacist or a GP, depending on the situation, that preferably has access to their notes through the system, and therefore they can effectively do a competent, structured medication review, which would fit with a lot of the principles of obviously all the stuff we're being asked to do as networks, as practices, and all that kind of stuff. And would clearly look at better integration, actually something of true value, rather than just tagging video consultations onto something.
Yeah, that perhaps where they don't need to be, I suppose.
Exactly.
The thing that what I was immediately thinking about was why why would Boots be making this move? What's the business behind it? I was wondering if they would get paid when we thought it might be medication reviews. I thought, is there a paper item on structured medication reviews? Are they going for that angle? But then I was wondering, actually, I think this might be part of a greater effort to move people to an online platform. They talk later about the Boots app, and I'm wondering if they're testing the water for encouraging a large proportion of their prescription business and the people that request the prescriptions to move to an online platform. Perhaps even then allowing them to close some of their store real estate. Is this a play to move to an online platform in order to compete with the mail order pharmacies that we've seen out there and move some of their business off the high street? And I wonder if that's the underlying motivation for Boots here. Doesn't mean it will be less convenient for patients, although I think a lot of our patients value being able to go into the store and talk live face-to-face with a pharmacist. So it might be a shame, but I thought maybe that's the driver behind this story.
Possibly, but it's interesting. The estates thing can work two ways, can't it? I mean, we talked about how the fact that the estates could be beneficial for particular areas as well, in the sense of obviously general practice has huge estates issues. Many practices just do not physically have enough room to see patients or to provide extra services because they just don't have the rooms, or they don't have access to the rooms necessarily, and therefore using other estates, like, for example, pharmacies, and potentially patching into them, so providing consultations through the pharmacies as a spoke for the hub mechanism. Actually, that sounds quite interesting and an opportunistic way of trying to deliver better healthcare to patients, probably from a network perspective, but, you know, there's clearly some logistical stuff here.
Yeah, so are you thinking that maybe at a primary care network level you could allow some more enhanced access to certain staff sitting within pharmacy estates and pharmacy buildings to do structured medication reviews, for example?
So our network pharmacists would really slot into this potentially quite well, providing additional service for the corporate pharmacists kind of
and there might be some commercial motivations for the pharmacies to do that. I mean, they like getting people in the store. I know a lot of their model involves while you're here for your Orlistat, do you want to buy a Mars bar or a shampoo or upselling? So it might be helpful for them to drive footfall. Just looking for synergies, really.
Well, I guess it's important to remember that the pharmacy contract for this year has radically changed compared to what they used to do. And pharmacies don't really get paid a great deal for the number of medications they now dispense, you know, in terms of, you know, it provides footfall, but it doesn't provide really income. And I think many of our pharmacist colleagues will probably agree with me on that. I'm by no means an expert on the new contract, but I know smatterings of it and stuff. But clearly that's an impact that's going to have on their finance and their viability. So therefore they have to provide other services. And is this another service that potentially would work? I guess one thing we haven't talked about, so we talked about Doctor Care Anywhere providing this service. What's really interesting is Boots already has a contract with another video consultation company.
So they've partnered already with Livy, haven't they?
Yeah.
So it's interesting that they're bringing another player who seemingly does a very similar service, looking at their website. It's interesting they're partnering with them too. And what do you think's behind that, Gandhi? Are they edging their bets here? What's happening?
I mean, we clearly do not know the minds of the Boots chairman and their board and stuff, but I suspect it's testing the waters in terms of how different companies can offer different services, and then are they going to think at looking at either, like you said, providing their own service, or, you know, focusing on one provider because they may be having discussions with us. It's an interesting move, let's put it that way.
Information gathering, testing, trying out different providers, different approaches, that's probably where they're at. There are a few other issues here, Gandhi, that I think we wanted to touch on. So integration with the clinical record system. I suppose if this is going further than just ordering prescriptions, to do a really good quality medication review, you need access to the clinical systems and possibly so, you know, is that going to be enabled? I don't know. It's something to think about, isn't it? Particularly if we're thinking about integration with primary care networks and their functions.
And I guess, is this already something that exists? You know, the NHS app is meant to enable patients to basically access their medication repeat history and sort out their medication repeats and all that kind of stuff. So why create an additional mechanism for doing that? You know, should we not be focused? I really
don't understand it unless they're doing it for commercial reasons, and there's other things that they can ask patients to do within their app that might generate revenue streams. But I'm always very cynical about these things.
We shall see. And as always, guys, if you want to check out more information about the NHS app, we have some content on that. So how to signpost your patients to register with the NHS app, which we're actually quite big fans of. We can see some real benefits of it.
I really like it. I think it's quite well executed, actually. So, moving into the final phase, we're trying to keep these episodes quite short for you guys out there.
Just before we do, so just a quick shout out to Roy Williams. Thank you for the comments. Yeah, definitely agree with your concept of how the procurement side of the notes things will be different for practice. So he mentioned in his practice that they've already paid for an off-site place themselves and they don't need the recoding because they've already done that. So how's that going to impact them? Important point, particularly when we look at a nationally procured service, because inevitably the structure of these things is quite rigid, unfortunately. So it's a one or nothing.
It's good on them for blazing a trail, though.
Definitely.
That's really good.
Cool.
Excellent. Oh, thanks for the feedback. Good to know we've got some people online.
Yeah.
So the final segment is where we're just going to give you guys a tip for the week. Might be something that we've come across that's interesting from a medical point of view, might be just sort of leadership management, or just pure enjoyment and interest. We'll give you a tip.
Yeah. So, do you want to go first, Andy?
Yeah. So I'm also manning the screen.
Yeah. There we go.
So mine's a podcast.
Okay.
So, and this is a podcast I really enjoy listening to. It's not a medical podcast. It's the Harvard Business Review After Hours podcast. And it talks about issues from a sort of leadership, management, business perspective, which is a lens I often like seeing things through. But they look at topical current events. It's a really great show. There's three professors who have a chat, a bit like we are. They have a chat. The idea is that they're after hours. Maybe they've got a glass of wine or a cocktail, and they talk more casually about things, or a cup of tea. But this particular episode that we'll link to in the show notes does have some medical relevance. They talk about the coronavirus, and yep, that's right, topical coronavirus right now. Maybe we should talk about that and the implications at some point, although not very well. I'm sure technology comes in there somewhere.
Yeah.
But anyway, they look at the coronavirus through a sort of economic lens, which is quite interesting. And they look at the human impact, but also the impact that might have on the economy of business. And that's something I quite enjoy looking at. But it's a great podcast, and there's some great warmth and chemistry between the professors who are on the show. And at the end, they do a little tip section like this, which is where I got the idea for this, where they sometimes talk about what they're watching on Netflix even. And it's actually quite interesting to get their take on it. So that's my tip.
Okay.
Broaden your horizons and try that podcast.
Cool. So mine's actually a clinical one. And most of our eGP learners will know that I tend to focus more on the non-clinical stuff, but actually I have to think this is an amazing episode and probably one of the best 30 minutes of my time, if I'm being honest. So it's a reference to our friends, the Primary Care Knowledge Boost team, who do some amazing podcast work, and their episode on antibiotic prescribing, to be honest, it is just packed full of information, and I would highly recommend anybody listen to it. I like using the hashtag EasyCPD. I'll be absolutely clear, this will nail so much of your CPD outcomes for your appraisal and revalidation. But not only that, in terms of impact on clinical work, it's just...
So again, I like to get myself set up right before I listen to a podcast. Yeah. Is this one that I can listen to in the car while driving, or do I need to sit down with my kind of pen and paper and take notes as I listen?
I would say this is one you're probably going to listen to a couple of times, if I'm being honest. Partly because, yes, you can listen to it in the car, and that's how I did. And then you will have things from it outside of that you want to take down and use and that kind of stuff. So you may want to listen to it a second time just to do it for that reason. One, to get the ideas. Second, to think about it a bit more and then get the links and stuff. Definitely check out the show notes and stuff, and they make some real references to some really cool tools. My favourite one is, and like they would talk about on the podcast, is When Should I Worry leaflet. If people want to see this, we'll put the link to our guide on that particular leaflet and how you can use it and stuff. But definitely a massive tip. But some of the nuggets, how you can talk to patients about prescribing antibiotics, the concepts of delayed antibiotic prescriptions, the use of and resistance and all that kind of stuff. It's just an amazing episode, and definitely recommend any clinician who prescribes to listen to it, because it will make a massive difference in the way that you work.
Wow, that's high praise. That's really got you enthused.
And it's interesting because it's not their most recent episode as well. So they've actually done another one since then. I've still haven't got around to listen to that one. But out of the ones they've done, including the one where they've got me on it, I'd say this trumps it.
Wow. Yeah. Excellent. High praise. So yeah, I'll definitely give that a listen, actually, Gandhi. That's one I've missed out on. So that brings us to the end of our Saturday morning health technology surgery. First time we've done this format. How was it for you?
Yeah. And again, a shout out to our people who have joined us live. So hi again to Roy Williams and Sandra Coleman. Thank you for your comments. Definitely agree with some of the stuff that you guys are talking about on the feed and things. And thank you to our listeners who are listening to us and stuff as well. So as always, we're available on all of our various different platforms: Facebook, Twitter, Instagram, LinkedIn. Definitely on the podcast. So if you're listening to this as a podcast, so we will process this out for you guys. Please leave us a review, preferably on iTunes. It's how the metrics and stuff work, but it would be really appreciative. And it tells us what you think, really. And obviously on the YouTube, click the subscribe button. We'd love it if you could do that. And leave us a comment. Yeah, ring the bell. And we will promise to reply to all the comments as we're doing right now and stuff. So, we will reply to your comments and stuff. Listen to our earlier stuff about the events we've got coming up. We're definitely keen to look at that. And we've got some really cool episodes coming up for you shortly as well. So definitely make sure you stay tuned for our future content.
So the new schedule is Saturday mornings, 11 o'clock. Yeah. 1 week, you will get a live update, just like this format. The week after, you will get some recorded content, and actually we're about to start recording that content as we close from this episode. And then the week after, you'll come out for a live update, and we're going to try and keep going with that schedule and build a little bit of Saturday morning clinic viewership going. So hopefully see you in 2 weeks' time.
Yep, catch you in the next episode, guys.
Okay, bye-bye.
Bye.
And I have to stand up and walk over.
Yeah, so
And
this is
actually,
our
no,
tech
I can do it from
failure.
here. Yeah, so this is where it's on the other screen. A little bit of a behind the scenes